Welcome back to Clinically Clear, guys. Today we'll be covering another very important viral keratitis known as herpes zoster ophthalmicus. Herpes zoster ophthalmicus. Let's go step by step. First, etiopathogenesis. Basically, varicella zoster virus is the causative organism, VZV. Normally, this infection is contracted during the childhood. So, child gets chicken pox. But immunity is good. So, it is a very self-limiting infection. Chicken pox goes away. But varicella zoster virus establishes a latent infection. Where does it like to go? It likes to go to the thoracic dorsal root sensory ganglion. It likes to go to the cranial nerve sensory ganglion. And under cranial nerve sensory ganglion, most important is the trigeminal nerve ganglion. So now there it has gone and established a latent infection. Then what happens? Let's say immunity decreases after some time because of old age, because of HIV, diabetes, steroid, organ transplantation. What happens? This latent infection gets reactivated. There is reactivation of the virus and the replication of virus. So now what happens? From the ganglion, you have the sensory nerves, right? Through those sensory nerves through which it had initially ascended, before it had ascended those nerves to come to the ganglion and establish a latent infection. Same nerves, it will now descend along and cause lesions, painful lesions in the dermatome that it supplies. If it is in the eye, then it is known as herpes zoster ophthalmicus. If it is in the skin, then it is known as herpes zoster shingles, so and so. So this is about just the etiological organism, that is varicella zoster virus. Then coming to general features of herpes zoster ophthalmicus. I am covering only the ocular part, herpes zoster ophthalmicus. It is only limited to one half of the face. Why? Let's say right trigeminal nerve ganglion is involved. Will it go and cause lesions in the dermatome supplied by the left trigeminal nerve ganglion? No. Only to the part. It spreads via nerves. It does not show local spread. So only to one half of the face it will involve. Then, as I said, mostly involves the fifth cranial nerve, trigeminal ganglion. Under that also, the ophthalmic nerve, ophthalmic division of the trigeminal nerve. Under that also, the frontal branches like a nasociliary nerve and lacrimal nerve. This nasociliary nerve is important. Why is that important? Because the nasociliary nerve, it supplies the eye. When it supplies the eye, it also supplies the nose, the tip of the nose, and the same side, the lateral side of the nose. It gives cutaneous innervation. So let's say there are cutaneous lesions in the tip of the nose and in the lateral part of the nose. So something has descended along the nasociliary nerve. So we can say that something has also caused lesions in the eye. So this is known as Hutchinson's rule. If you see skin lesions on the tip of the nose and on the side of the nose, then you can automatically assume that there is ocular involvement also. This is known as Hutchinson's rule. So these are the general features. Then clinical features occurs in three stages: acute stage, chronic stage, and relapsing stage. So acute stage, what happens? Acute stage, you have a prodromal phase. This prodromal phase basically has systemic features like fever, malaise, lymphadenopathy. Important. But what's more important is this severe neuralgic pain along the course of the nerve. Along the course of the trigeminal nerve, patient feels that the severe shooting pain. This only doctors can diagnose just based on that shooting pain along the course of the nerve, that neuralgic pain. And at the dermatome supplied, there is paresthesia, abnormal sensation like tingling, itching, numbness, etc. And then what happens? This prodromal phase eventually goes into eruptive phase. Eruptive phase is where the neuralgia reduces, the neuralgic pain reduces, but skin lesions come up. What are the skin lesions? Red edematous maculopapular rash, pustules, vesicles. These pustules and vesicles, they burst, leading to crusting. Healing of these crusting occurs in the form of pitted scars. Then edema of the eyelids. Whatever name comes in dermatology, you write that skin lesion will be present. So pustules, vesicles, crusting, maculopapular rash, everything. That is eruptive phase. Eruptive phase then last goes into ocular phase. Ocular phase, what happens? Skin lesions decrease, ocular lesions come up. So you can have conjunctivitis. Conjunctivitis can be acute follicular conjunctivitis, or it can also be acute mucopurulent conjunctivitis. Usually viral, meaning it is acute follicular conjunctivitis. Then keratitis, four forms of keratitis. Epithelial punctate keratitis, I've already covered in the previous video. Tiny coarse punctate lesions of the epithelium. nummular keratitis. This is at the level of stroma. Very, very important. Nummular keratitis is not on the corneal epithelium. Coin-shaped granular stromal lesions is nummular keratitis, as you can see in this picture. Nummular keratitis. And disciform keratitis. What is disciform keratitis? Basically, edematous stroma leads to the edema. The corneal edema is in the form of a disc. That is disciform keratitis. Then you can have something known as pseudodendritic ulcer or microdendritic ulcer. Why is it known as pseudodendritic ulcer? See, dendritic ulcer is seen in herpes simplex virus, where the dendrites have knobbed ends. Here, the dendrites have tapered ends. So, because they have tapered ends, they are not true dendrites. They have tapered ends. So, because of that, there is pseudodendritic ulcer. Apart from that, you can have every other eye infection you name: scleritis, episcleritis, iridocyclitis, then trabeculitis. Trabeculitis will block the trabecular meshwork, leading to glaucoma, etc. and etc. This is about acute stage lesions. So, prodromal phase, more of neuralgic pain. Eruptive phase, all about skin lesions. And ocular phase, every type of infection in the eye. Elaborate about keratitis, where nummular keratitis and pseudodendritic ulcer is the new types. Then coming to chronic stage lesions. Chronic stage lesions occur multiple decades later. The most important is something known as post-herpetic neuralgia. Post-herpetic neuralgia, basically there is persistence of this neuralgic pain even after the disappearance of acute stage lesions. Now, neuralgic pain in acute stage, prodromal phase is normal. But even after the disappearance of all acute stage lesions, if there is neuralgic pain, then it is known as post-herpetic neuralgia. And this post-herpetic neuralgia is especially worse at night. And if this post-herpetic neuralgia is associated with anesthesia of the dermatome supplied by that nerve, so anesthesia of that particular dermatome and neuralgic pain, then it is known as anesthesia dolorosa. Important MCQ question. Anesthesia dolorosa. Then chronic conjunctivitis can be there, chronic uveitis, chronic scleritis, lid scarring leading to trichiasis, and the cornea part is in the form of chronic mucus plaque keratitis. This is also an MCQ question. Chronic mucus plaque keratitis. So this is about the chronic stage lesions. And what is the complication of these what do you call it? Herpes zoster ophthalmicus. See, it has come through the sensory nerve. It will go and cause complications by causing palsy of the motor nerve, the third cranial nerve, the fourth cranial nerve, the sixth cranial nerve, the seventh cranial nerve. The most common is third cranial nerve, oculomotor nerve. This is the complication. Treatment. Treatment can be divided into three parts: systemic therapy, topical therapy, and treatment of post-herpetic neuralgia. Systemic therapy is mainly focused on acute stage lesions where you have severe symptoms. So you will immediately start the patient on oral antibiotic ASAP, because this will reduce the pain, it will reduce complications, it will reduce post-herpetic neuralgia. You will give 5 times a day for 10 days acyclovir 800 mg. So heavy dosing, oral acyclovir. Oral analgesics like paracetamol for the severe neuralgic pain. If it is very, very severe, you can even give pethidine. Then systemic steroids. Systemic steroids also reduce the pain and inflammation. They prevent post-herpetic neuralgia. And you will also give systemic antidepressants like amitriptyline. Patient might get depressed, so many lesions, so much neuralgic pain, so much. It's a very painful condition, very horrible condition, herpes zoster ophthalmicus. So patient might end up going into depression. So that is about systemic therapy. Topical therapy, for the skin lesions, you should not give calamine lotion because that will cause further crusting. You should give steroid antibiotic lotion. Steroid antibiotic lotion. Topical for skin. Topical for eyes, every medication you name, you will give. You will give topical steroid. Why? To reduce inflammation, to reduce pain. Topical antibiotic to prevent any secondary infection, bacterial infection. Topical antiviral for the herpes, for the varicella zoster virus. Topical atropine to reduce pain. Topical lubricants, soft bandage, contact lens. Then topical timolol, beta blocker to prevent glaucoma. Then topical mucolytics like acetylcysteine for the breaking the mucus plaque in chronic mucus plaque keratitis, etc. Then coming to the treatment of post-herpetic neuralgia. Treatment of post-herpetic neuralgia, you have, just a second. Yeah, treatment of post-herpetic neuralgia, you have capsaicin and lidocaine skin patches, capsaicin skin patches and topical anesthesia lidocaine skin patches. These are to reduce the pain. And you have anti-epileptics like carbamazepine, gabapentin, and also antidepressants like amitriptyline and nortriptyline. These are to improve the nerve functioning. So this is how you treat post-herpetic neuralgia. Capsaicin and lidocaine skin patches to reduce the pain, and antidepressants and anti-epileptics to improve the nerve function. So that is about the treatment of herpes zoster ophthalmicus. So systemic therapy and topical therapy and treatment of post-herpetic neuralgia. Systemic therapy, analgesic, antiviral start immediately. Analgesic, steroid and antidepressant. Topical for skin, steroid antibiotic lotion. Topical for eye, everything you name, you can write, you can give. Post-herpetic neuralgia, anti-epileptic, antidepressant and capsaicin and lidocaine skin patches. That is it for herpes zoster ophthalmicus. I hope you guys enjoyed the video. Thank you for watching.